Hello, everyone. Thank you for joining this presentation. It is my great pleasure for me to share my experience with the FAP-targeted PET imaging and molecular radiotherapy in cancer patients. So just to be sure we're all on the same page before we start talking about FAP and FAPI, today we're going to talk about the STROMA. The STROMA can be seen as kind of the reaction of the host to the invasion of the cancer cells. The cancer cells induce a wound healing response, and this response, associated with some inflammatory changes, can be called the tumor stroma, the desmoplastic reaction, the tumor microenvironment, or cancer fibrosis. And of course, this has great properties for targeted treatment or imaging, and it's a target of high interest for the whole oncology community. One of the main cells content in the stroma is the cancer-associated fibroblast, the CAF. And this CAF, they express a lot a protein called FAP, fibroblast activation protein. And now we have radiopharmaceuticals that are specifically designed to bind to it with high specificity to either deliver beta positron radiation to be used for PET-CT imaging, or even now people are thinking of using it for treatment by delivering alpha local radiation or beta minus radiation. That would be the ultimate goal of FAP-targeted radiopharmaceutical therapy. So when you look at the gene expression of FAP in the protein atlas, you can see that the level of expression is very low in almost all organs, except the uterus, for some reason, at some background level all the time. And the transformed fibroblasts or the activated fibroblasts, they have a very high level expression. So just by looking at this graph, you can guess that if you have a way to get there, you will have either a very contrasted imaging agent or a drug with a very high therapeutic index with low uptake or low distribution into normal organs. And so that target is in fact known for quite some time. For example, in the 90s, there was already some attempts to use this target for radiopharmaceutical delivery. And here is an example of radioimmunotherapy with iodine-131 with using an antibody called F19 that was specific for FAP. You can see these images, kind of vintage of SPECT CT of FAP expressing liver metastasis and the planar images obtained with iodine-131. But a little bit like with PSMA or dotatate, this was not ready for prime time. There was no really PET-CT. It was antibodies only. So what make really the difference during the past years or decade is the creation of all these small peptides, low-weight molecules that have maybe much better properties for targeted imaging. Because they are smaller, they go very quickly from the blood to the target, and so they are much easier to use than big antibodies. And our colleagues in Heidelberg, they have a great radiochemistry research development team over there, and they developed this quinolone-based class of radiopharmaceutical called FAPI. So the I stands for inhibitors. And you probably all have seen these very impressive images with great contrast, high tumor to background ratio, black on white, lesions to background. These came out maybe in 2018, 2019. There was a lot of hype. It had the image of the year at the meeting of the annual meeting of the SNMMI in 2019. Since then, there were multiple publications, multiple, let's say, editorial interest saying, will FAP replace FDG or not? And so it generated a lot of hype. when you look at PubMed, I did a search in February 2022. So now I think we're in March, so it may have increased again significantly. You can see that it started in 2018, and now we are reaching close to 300 papers. I have to say, most of the papers there are in fact case reports. There is not a lot of good, big prospective trials with big cohorts. It's either retrospective studies or case reports. It's interesting to see where these are coming from. Mostly China, you can see more than half of them. Then from Germany, the creators kind of. Turkey, they did a lot, they did quite some. And then the USA, India, Thailand, and Iran. These are the countries where there has been some experience with FAPI PET-CT. In the US now, if you want to do something with FAPI PET, you have to go through a company. They acquired the license of the FAPI compound in 2019. This is Sophie from Heidelberg University. And now they just recently have obtained an IND to perform clinical research using the FAPI PET-CT compounds. Their IND will be initially valid for pancreas cancer study, a phase 2 trial. At UCLA, we started way before that, and we had an agreement between Heidelberg and UCLA. We used a different regulatory pathway than the IND to conduct clinical trials. We used what we call the RDRC. It is another regulatory pathway that allows the use of a new tracer, a new radiopharmaceutical in human, but without all the preclinical required data that is usually asked for an IND. So it allows the use of that in patients, in human, but you're capped in terms of the number of patients you can do, and also in terms of diagnostic efficacy parameters you can prospectively assess. So these studies are mostly exploratory studies, biodistribution studies, in which you just administer a new tracer and you basically look at the biodistribution. You can see here that we have various cancer types allowed in these studies. We have now enrolled 65 patients as of early 2022. The aim of this study, because we're not allowed to talk about pure diagnostic efficacy with predictive value, sensitivity, specificity, here we aim at validating the biodistribution of the tracer with the immunohistochemistry of the FAP expression, of the target expression by immunohistochemistry. So we recruited patients who were scheduled to undergo surgical resection of their tumor. So only patients scheduled to undergo surgery. The recruitment is hard because you need to squeeze in a scan in a patient who already had a PET-CT scan, FDG, before, who is scheduled for surgery, and you need to squeeze in a FAPI PET scan that will basically have no impact on his clinical care. So the recruitment is a bit slow, but we're getting there, and we can generate nice correlation between IHC scoring and SUV from this data set. We have recruited 65 patients, as I said before. You can see here the various cancer types that we have so far. We have a strong collaboration network with our prostate cancer and sarcoma colleagues, specialists. So that's why there is these high numbers in these cancer types. We have published recently a preliminary analysis with the first 15 patients analysis. These patients were recruited between December 2019 and May 2020. You can see here the various cancer types, mostly colorectal cancers. They all had surgery within, let's say, almost kind of close to 2 weeks after the FAPI PET scan. And when surgery, and what we did, we looked at the uptake of the primary tumor. You can see here an example of a sigmoid colon adenocarcinoma with very intense FAPI uptake. We look at the staining. You can see the FAP IHC staining of the cancer tissue here. And we look at the adjacent tumor adjacent to the tumor region, and we compare the SUV in this adjacent region within the normal region on the same slide that was obtained in pathology. Here is another example where you see the primary tumor, very focal, intense uptake in this colon adenocarcinoma. And then we take the SUV in this normal region close to the tumor, and we look at the IHC scoring in the region adjacent to the very strong IHC scoring system in this FAP expressing region of the primary tumor. And the highest FAP immunohistochemistry score were observed in pancreatic, esophagus, and breast cancers. The FAP staining was exclusively confined to the tumor-associated stromal compartment in most of the patients. And what was very interesting is to see that the staining intensity was greatest in the stromal areas that were either within or immediately adjacent of the malignant compartment of the tumor. So the closer you are to the tumor cell, the more FAP expression there is. And the further you are, the less FAP expression you have. And in non-cancer tissues, when you do see some FAP protein expression, it was primarily observed in capillary and small vessel endothelium. So this may be important to know for the future. When you look at the correlation, you can see that what you see on the scan, the signal intensity as assessed by the SUV and the IHC scoring system that was graded by 2 independent pathologists correlate nicely. So the more you have FAP protein expression as assessed by IHC score, the more intense is the signal on PET. And when you look at the cancer lesion versus the non-cancer adjacent tissue that I just showed before, you can see that the signal both on the IHC scoring and the SUV is higher in the cancer than in the non-cancer adjacent tissue, very close by. And now we're getting close to 70 patients done at UCLA, so we're learning how to read these scans and the biodistribution of FAPI PET tracers. And there are some interesting things to be known before we can move further. I like this example here. This was an esophagus cancer patient. You can see the primary tumor in the distal portion here. And this patient underwent resection and got his whole esophagus removed and analyzed for pathology. All these parts, the mid portion here was in fact not cancer and just fibrotic or inflammatory changes. Of course, when you look at that, it's pretty hard to make the difference and make a final call on your read. So we start to see, many non-oncologic findings that we reported. You can see here the breast tissue can have strong FAP expression under certain hormonal conditions. I will go back on that later. You can see that any granulomatosis process, any disease like tuberculosis, sarcoidosis that induce a granulomatosis or inflammatory process can induce a strong FAP activation and expression. You can see that thyroiditis as well can have a strong signal on FAPI PET. There are now 2 papers that I like very much to describe all the non-oncologic findings that we could call pitfalls in the context of cancer application, but we can also use it for non-oncologic applications, of course. Today, I'm going to talk about cancer patients, so I will call it pitfall. You can see that inflammatory lymph nodes, like with these pitfalls, I think many of them, they are unspecific to a tracer. You see that with most of any nuclear medicine tracer at the end. So inflammatory lymph node, osteoarthritis, hemorrhoids, fractures in the bone, all the degenerative changes, the inflammatory changes, esophagitis, pneumonia, all that you see, and they are nicely summarized in that paper. It is actually what we observe as well in our cohorts. So if you put the same graph that I just showed you before, when we look at the IHC staining and the FAPI SUV on a selected sample, you do the same, but this time you compare all these benign uptake, and you see that you have a significant overlap of FAPI SUV for cancer lesions or benign lesions, or inflammatory lymph nodes versus malignant lymph node. So of course, FAPI and FAP is not specific to cancer. It is just fibroblasts activated. In this nice paper, it is more pictorial. There are some images, so I choose to display that here. It is done by our colleagues in Essen. That summarize pretty nicely what was in the table before and our experience as well in our patient of 70 patients at UCLA. So in the salivary gland, there is a little bit of level of expression at various levels. I think it depends on the prior history of the patient in terms of salivary gland exposure to potential traumatic causes. Interestingly, the optic and oculomotors muscles have some signal, so that's interesting to observe. As expected, anything in the mouse that is related to dental implant, dental extraction, any gesture in the mouse would induce some kind of expression of FAP and reactional processes. All the scar tissue, the remodeling in the muscles, you can see here, that's probably a contracture or some muscle benign inflammatory process that induce fibrotic reaction. This is the most common one, I think, classical, the degenerative joints and bone findings that you can see here. You see on the left temporomandibular joint, here in the spine, in the posterior processes, here also in the spine, anterior processes, and here, interestingly, you see a very focal and strong signal in intra-spongious hernia. You see that on FDG there was nothing, and there is some FAP expression and fibroblast recruitment in that. Yeah, I like to show this example because this lesion, which was, of course, very suspicious of cancer, depending on the indication, the SUV max was 14, as you can see here, was biopsied and was, in fact, a tuberculous granulomatosis inflammation. Patient responded well to anti-infectious treatment. But just to show you that anything that creates some fibrosis and remodeling of the microenvironment surrounding a lesion would enhance the FAP expression and have a strong FAPI signal on PET. The hormonal status in specifically female patient, but probably also in male, may influence the uptake of some organs, such as the breast or the uterus and the endometrium here. That's very normal to see the uterus like that, and also the breast. And they really, depending on the hormonal status, this can be sometimes very intense. You can see here the SUV in premenopausal patients versus postmenopausal patients. One of the main pitfalls, and that specifically when a patient will be interested to look at pancreas cancer indication, is the pancreatitis. The pancreatitis, the inflammation, and the fibrotic processes that occur in the pancreas have a lot of FAP overexpression mechanisms. And you can see here diffuse uptake in patients with pancreatitis. That's pretty frequent to see that, specifically in a patient population with suspicion of pancreas cancer. So people have tried to get rid of this background signal diffuse by doing late imaging acquisition. You can see here 2 studies showing images over 3 hours, and you have more or less a stable uptake in the tumor lesions, whereas the background pancreatitis parenchymal uptake decreases over time. So it's always a little bit like with FDG or with any other tracer. Often in cancer imaging, you do late imaging and you try to get this differential uptake time. What is interesting in that study is that they look at 100 patients with even focal uptake in the pancreas. They found 7 cases. They follow all these cases, and at the end, all the pancreatic lesions were proven to be non-neoplastic. So they were either pseudocystis, pancreatitis, IgG4, but even when it's focal, it doesn't mean it is cancer when it is in the pancreas. So that's a clear pitfall here to be known. So the question that come all the time now that I'm usually asked is what is the killer indication for cancer imaging and diagnostic? We start to see some meta-analysis and review a little bit in PubMed from this amount of literature that is available. But of course, like I said, there is mostly retrospective studies, case reports, the data quality is not excellent. And when you have on a patient-based analysis, sensitivity of 99%, primary tumor 100%, I mean, these numbers show just a strong patient selection bias, and that maybe the question asked to the diagnostic purposes were maybe not appropriate in a real life manner. I think these numbers would be very different once we start to do true prospective trials. So let's look at it a little bit when you compare, of course, FAPI versus FDG, because everybody is talking about how can FAPI replace FDG. It started in 2019. I put here all the studies that have intra-patient comparison of FAPI and FDG. So patients who underwent both scans more or less at the same time and that have reported finding, and not independent cohorts. So in that study, there was 6 patients in Germany, then a lot of Chinese studies, 75, 68, 123, Turkish studies here, another German study, a multi-center study that pulled data from Germany, UCLA, and South Africa, and a review. And when you try to extrapolate that and extract a little bit of a signal from all these studies, it's not easy. At the end, they report mostly the differential SUV between organs, between lesions, head-to-head. And so clearly you have a higher tumor to background ratio of FAPI over FDG in many situations, specifically in organs where you have high FDG uptake as a background normal, such as in the brain, the oral mucosa, the liver, the gastrointestinal or digestive. There is always like some background activity, and sometimes the just FDG signal of the tumor lesions can be low, or in the bone, which is a common limitation of FDG PET imaging. So these are observed and these are pretty clear. So that's a given. What is unclear is how these properties can translate into actual useful improved diagnostic performances. And it seems from the studies that are published and all the cases that are reported that there may be a potential superiority of FAPI for metastasis detection in bone, brain, liver, and the peritoneal carcinomatosis, and for the primary detection of this cancer type: breast, cholangiocarcinoma, gastric cancer, head and neck cancer, or pancreas cancer. I will display a couple of examples here that I personally chose, so it's completely biased towards my opinion and basically tell what I think that may work. So let's look first at the bone metastasis detection. In that study, they reported the FAPI and FDG SUV in osteolytic and osteoblastic lesion of almost 100 patients for each. And you can see that in these 100 lesions, the SUV max was higher with FAPI than with FDG. And however, there were more FAPI false positive than with FDG. And this echoes to what I just showed before with this strong reaction in some degenerative processes. Or for example, the granulomatous pitfall that I showed before. Here is just a nice example when you see more microenvironment reaction and FAP expression in these lesions than with FDG, where you just purely see the glycolytic activity of the tumor, which is often lower in bone metastasis. So potentially better for bone metastasis detection. Liver metastasis can be very tricky with FDG and even with MRI sometimes. In this little study, 31 patients, retrospective, that were kind of basket staging, restaging indications. They all had metastasis in the liver from colorectal cancer, pancreas, or gastric cancer. You can see here the different tumor types that were included in that study. Well, you can see that the SUV with FAPI is a little bit higher than with FDG, not that much, but a little bit. But you can see more importantly that the tumor to background ratio are much higher with FAPI than with FDG. And so that's maybe the difference in the liver. And there were 29 cases positive with FAPI versus 22 with FDG. So there were 8 cases that were negative by FDG and positive by FAPI. So potentially a good role, especially in gastric cancer. Maybe it seems that that's where there is the highest signal for liver metastasis staging. Peritoneal carcinomatosis. This can be tricky sometimes. This can upgrade patient to a very important staging information for treatment direction and surgical management. And in a study that looked at 46 patients with suspected peritoneal malignancy, there were a median SUV max of 3.5 with FDG versus 9 for FAPI. So it seems that the peritoneal carcinomatosis induce much more fibrotic process and activation of fibroblasts, in particular in the gastric cancer subtype. The PCI score, which is a way of scoring the extent of the peritoneal carcinomatosis, was much higher with FAPI than with FDG, and the sensitivity was also much higher, 97% in 72%. So potentially a good role for peritoneal carcinomatosis detection as well. Now let's look at some primary tumor different subtype and potential indications. So pancreas cancer, as I said, the main study that will occur prospectively in the US, the first one will be in pancreas cancer. I showed that before. What has been published so far in PubMed is mostly, again, a retrospective study. Let's look at them. Here you have 36 patients with suspected or diagnosed already pancreas cancer. Often in these retrospective studies, you have a mix and a basket of different indications, which is makes very hard to extract a strong signal from it. And you can see that FAPI PET scan upstage 6 patients, so 26% of the cohort, and change the management in 8% versus FDG. And when you compare it versus contrast enhanced CT, it upstaged 20% of the patients and changed the management in only 1 patient. And interestingly, you can see that the intense FAPI uptake was observed throughout the PANCREAS is almost half of the patients. So that may render difficult the actual usefulness in that setting. You can look at that. This was not mentioned, but 30% of specificity for FAPI, that makes it quite concerning. So to get 100% of sensitivity, they had basically to call everything, and the specificity decreases a lot. So maybe if we keep a good level of specificity, the sensitivity would be much lower. In another study here, 33 patients, so more or less the same size. The detection rate for primary tumor was 100% with both tracers. There was, again, in half of the patient, parenchymal uptake in the background, observed only in 13% of the patient with FDG. There were more lymph node detected with FAPI, but there were more liver metastases detected in FDG in that cohort. So at the end, it is a bit unclear how it will be easy to prove or not that FAPI can be really useful in that setting. And they conclude with that MRI is required for primary tumor and liver staging in any case. And MRI would be hard to beat. In that little series of 19 patients, they look at the impact on management just on FAPI versus contrast enhanced CT. The TNM stage was changed in half of the patients. These patients had either newly diagnosed or recurrent disease. And this change of TNM lead to a management change in 36% of the patients. So you still see things on the scan that are maybe helpful for your management choice. But to me, it would be very difficult to show that all these data prospectively. Let's look at an indication that for me will probably work pretty well. It is the gastric cancer. Let's look at this first series, 10 patients, the detection rate of the primary tumor that is usually, let's say, low with FDG. Here it was 100% with FAPI, 50% with the FDG. The SUV max was much higher. You can see 16 versus 5. And more importantly, the TBR was also much higher because often with FDG, you have this gastric wall signal that makes the read very difficult, almost impossible. And so the detection of a regional lymph node was comparable, and the peritoneal carcinomatosis was detected more with FAPI than with FDG as suspected. Another series here of 20 patients. You can see that FAPI PET was superior to FDG for primary tumor and again peritoneal metastasis detection. And you can see that FAPI and FDG were equivalent for lymph nodes, liver, bone, and ovarian lesions. Here in red are all the FAPI intensity signal or ease to read for different regions. And here in blue are the one for FDG. So you can see that for most of the cases and regions, FAPI were show the more intense visual scoring system. In this bicentric retrospective analysis that included 38 patients, for the detection of primary gastric cancer, FAPI sensitivity was 100% versus 80% for FDG, and metastatic lesions 60% for FAPI versus 50% for FDG. So it seems that this higher tumor to background ratio, as shown here, can enhance maybe the detection of primary tumor and also metastatic lesion in this gastric cancer staging. So that may be a good one. One other that I like personally is the cancer of unknown primary, because I think there is a strong unmet need. And there are some early reports, for example, in this 18 patients cohort with all FDG negative scan. You can see here the bilateral uptake that makes, you don't know if there is an asymmetry or not. Where on the FAPI scan, it was clearly on the right side. So the primary tumor was detected here. And at the end, they detected almost 40% of the primary tumor in patients who had prior FDG negative. You can see, though, that the level of uptake is in the same range, but the TBR may be a bit improved. So that's promising data. But in this other series of 8 patients, the primary was identified by both FAPI and FDG in all 8 cases. So again, if you have to do that prospectively, maybe promising, but it may be hard to really demonstrate superiority prospectively. For breast cancer, there are some early reports that show nice uptake, nice expression of the target FAP in the primary tumor across various disease stage and types, subtypes. Same in the lymph node metastasis. You can see here this black on white lesion, both in the primary tumor and the lymph nodes, in this cohort of 18 untreated primary breast cancer. So that there may be a good potential here. But again, you will have to beat FDG and beat other modalities such as MRI, so that may be not easy. In this little retrospective study of 50 patients, almost, so good numbers. The uptake seem higher. You can see that the FAPI uptake is much higher than the FDG uptake. But at the end, because it was a basket study without any clear diagnostic accuracy endpoints, the staging on impact was really unclear. They just show that the uptake may be higher and that may lead to change in stage. More or less the same findings here in 20 patients where the sensitivity was higher with FAPI. You can see that the specificity was a bit lower. In the breast, you have some changes, so that can be a pitfall. They report higher FAPI TBR, higher FAPI SUV, but again, the staging impact was unclear. And I think the last one I'm going to talk here is the sarcoma indication. In this paper with the 45 patients with recurrence of tissue sarcoma, you know, sarcoma is a very heterogeneous box of disease where you have many subtypes that behave very differently depending on their grade. And I highlighted here in red the ones in which FAPI is very strongly expressed by both, probably also the cancer cells themselves, because it's it's a fibroblast cancer potentially. And in blue, the ones with much more FDG uptake. And it seems that for liposarcoma, malignant solitary fibrous tumor, interdigitating dendritic cell sarcoma, FAPI can be much better than FDG. And on the other hand, undifferentiated pleomorphic sarcoma or rhabdomyosarcoma, they seem to be much better with FDG. The low-grade tumor, G1, also much more intensely seen with FAPI than with FDG. This I can clearly confirm in our cohort as well in UCLA. In this study done in Germany, where they try to assess the impact on management of patients who undergo FAPI PET imaging for bone or soft tissue sarcoma. Again, it was a basket trial with staging or restaging indication. They correlate nicely that the FAPI SUV and the FAPI IHC score correlate. When you have high FAPI IHC score, you have high FAPI SUV. And they report a change in management in 30% of the patients. These are the 30% of the patient with the management change. Now, when you look at the detection efficacy, the numbers look pretty similar between FDG and FAPI. So again, it is unclear to me how you can place FAPI in the diagnostic and treatment algorithm and show prospectively a good benefit. I think many studies need to be done, and I look forward to see the results. One key thing, and I think the main application for FAPI PET is to act as a biomarker for FAP expression in case you have a good FAP-targeted therapy. And if we talk about FAP-targeted radiopharmaceutical therapy, this FAPI PET will be, of course, the entry gate for any patient who is considering such therapy. We start to have like some kind of reports in PubMed on the early experience of FAP-targeted molecular radiotherapy. In February, I was able to kind of extract the data from 65 patients in PubMed. So the experience started in Germany, of course, with about a dozen of patients treated with yttrium, FAPI-46, FAPI-04. And then there were some patients treated in Iran and China with lutetium-177, about 30 patients with FAPI-46 and FAPI-04. Then there is the FAPI-2286 compound that was developed by Professor Bohm in Bad Berka, and I just recently reported I will talk about that. And there is this new compound, Dotaga SA FAPI-2, that is used in India now, that I will talk about as well. So one thing that I try to look for is this kind of images. PSMA molecular radiotherapy had very quickly an early hype. It was a blast right away. There was this case report showing this impressive response both on serum markers and on images with this treatment coming from Germany. This started probably in 2015. Same with actinium, these very impressive images with great response both by PSA and images. Well, I didn't find anything like that with FAP-targeted therapy. I tried to look for it. Here you have scans. These are FAPI scans before and after. 1 cycle, 2 cycles, it depends. And you see, you don't get these types of images. Here are even FDG. You can see the heart signal here, the brain signal, and you can see that the response by FDG is not great as well. So I wasn't able to find these images just because they don't exist. And of course, if they would exist, they would have been published already a long time ago. Let's look a little bit at the efficacy data that is reported in these early cohorts. They usually have treated patients very end stage, very advanced. So it is difficult to get any types of response, of course, because these patients are very close to the end. So you can see here the type of response. There is no PR, no CR. You have some SD and some PD. Similarly, as well here, PD or SD, but no PR. Again, of course, it's very advanced patients, so it's kind of hard to get any types of response with any therapy. But we don't see a good signal of efficacy. These studies were really made for feasibility purposes and safety. One of the main drawback, I think, that makes it for now not a successful approach is the retention time of the FAPI class compounds. They have a fast, maybe they recirculate after they get internalized into the cell after binding. And so they don't, it seems they don't stay a long time in the tumor lesion. And if you deliver radiopharmaceutical that has a half-life, for example, like lutetium of about a week or actinium about 10 days, or maybe you need more time than just a couple of hours to deliver the energy that you need to induce sufficient damage to the DNA. And when you look at these images here, for example, you see this good target expression on the baseline PET, a good delivery of the lutetium FAP-46 at 24 hours, but rapidly it seems to decrease over time after 72 hours, and it goes into the kidney and the urine. Same kind of images here in a pancreas cancer patient. You see uptake at the beginning, but then rapidly you don't see this very contrasted late images that you see like that with PSMA. You know that your treatment went there right away, and at 24, 48, 72, 9 days, you see the retention of the lutetium PSMA radiopharmaceutical therapy in your target, continuously delivering radiation and inducing damage, and that's why it works. And that's probably maybe one of the reasons why it doesn't work for now with FAPI, with this fast recirculation time. So there is a high interest of the scientific community to improve the retention time of the FAP-targeted radiopharmaceutical therapy agents. There have been multiple attempts that has been made already so far. One is to add albumin minders and to prolong the blood circulation time. And with more circulation time in the blood, not excreted into the urine, you give more time and differential time between increased continuous uptake from the tumor, whereas it's flushed out from the normal organ. So that's the theoretical concept and the aim. And there is also a way that is called multimerization to increase tumor rotation. The binding motif or the targeting moiety is doubled on the carrier. So you have two attachment ports to the target, basically to be more attached, and that the radiopharmaceutical stays there with two attachment link. There is also FAP-2286, which is a cyclic polypeptide linked to a DOTA chelator. So it is not a quinolone-based molecule. This one is owned by Clovis now in the US. This was developed by Professor Bohm in Bad Berka. And you can see here that it seems that the retention time is much better with increasing over time. And the early human experience has been reported recently in the JNM. You can see the FAP expression with the FAP-2286 gallium compound, and then the scans obtained after injection of the treatment with lutetium FAP-2286. And you can see a very good, let's say, retention over time. After 10 days, you see still good target retention. There is more kidney signal lately, so maybe we'll have to see how this translates into kidney toxicity or not. And if you look at the efficacy results that are published in this little cohort of 10 patients, again, there is no strong signal of tumor response or efficacy. It was, again, more about safety and feasibility. Here you see only a progressive disease because, again, these patients were really end-staged. I like to show here that because I find that very interesting. This Dotaga SA FAPI2 from the Indian studies. Here you can see that after 168 hours, you still have a pretty good signal in the tumor lesions that you want to treat. And you see a very good response both on the serum marker here. This was a case of radioiodine refractory differentiated thyroid cancer. And you see a good imaging and serum marker response. So that's maybe the most promising image I was able to extract from PubMed. So this was in the thyroid cancer patient population. Here is another example with a really diffuse lung metastasis of radioiodine refractory differentiated thyroid cancer. And you can see that this double-headed linker to the FAP target seems to work well because the radiopharmaceutical seems to stay there. And this was, again, with lutetium. And you can see that after 96 hours, you still have a good radiopharmaceutical retention in the targets. And again, interestingly, we start to see some response based on various criteria, but there are some patients that seem to respond to this treatment with this FAPI compound. So that's maybe a promising approach. I think that was an interesting report from India. Of course, small cohorts, always very difficult to reprove prospectively. And if you look at the dosimetry and trying to understand a little bit more per lesion and what these compounds can deliver as energy for radiation, you can see that for the kidney it's pretty safe. I put here the lutetium PSMA, the lutetium dotatate, the commonly approved and used one, just for comparison. So you see that there is kind of more activity in the kidney. So the FAPI compound may be more worrisome in terms of kidney toxicity, and this can have an impact for the FDA and all the regulatory approval, of course. The bone marrow toxicity is very low. There's no bone marrow uptake a lot. And when you look at the tumor doses, of course, there is always a pretty significant range in the different values that are given in all these studies. Usually the classical one that are retained is like something between 3 to 5 gray by gigabecquerel for lutetium PSMA and lutetium dotatate. This is usually in the range of 1 with yttrium FAPI-46, lutetium 177, FAPI-46. It seems that it's 3. It seems to be better with FAPI-2286, lutetium. And interestingly, in the DOTA GA-SA FAPI-2, it was 10, so much higher in that report. So maybe that's promising. And it was kind of interesting for me to observe all this rush of all the company to get licensed all these new FAP-targeted radiopharmaceutical compounds. There are multiple players in the market now. They all have various compounds. So it will be very interesting and exciting to see all these attempts and the future in the next 3, 5, 4 years with all these new compounds. With that, and thank you very much for your attention. I hope you enjoyed the talk. And feel free to send me an email if you want to ask me any question about FAP-targeted diagnostics. Thank you very much.